All right, thanks. All right, we're in the home stretch here of the last session. We're going to focus on the critical role of partnerships, as we need a diverse group of partners to be successful in achieving goals for hepatitis elimination. We're going to be focused on the role of industry as partners. So we have a combination of panelists online as well as here in the room. I'm regretting my mother did not name me Chris at this point, I guess. So we could have a trifecta up here, but otherwise we will begin the introductions with those in the room, and then we will see who's online, and then I'll start asking some introductory questions, but I encourage all of you to be thinking about what questions you would like to, or comments you would like to have, and I encourage all of you to come up, and let's make this a very interactive discussion. So, Chris, I'll ask you.
So, thank you, John. So maybe a short introduction. So my name is Christophe Martinaud. I'm working in Cepheid. So most of you know this company, in vitro diagnostic company, who has many products, and including HIV, HBV, HCV, for HBV and HCV, viral load, and in some part of the world, point of care claim for these assays. I'm a director for Europe, Middle East, and Africa in medical affairs. And just to let you know that what is in the scope of medical affairs is to provide medical and scientific inputs from the idea of diagnostic tools until its commercialization and post-market surveillance, including studies. And what is not in the scope of medical affairs is the pricing. I'm sorry for that. So just to prevent any question to which I could not be able to answer, either the market access is not in my pocket, so I can give you the name of the people who are more involved in these areas, but just feel free to ask me more about the clinical studies and the generation of evidence.
Okay.
Yeah.
That's a good start.
So good afternoon, everyone. So another Christophe from France. And so I was a physician during 23 years in Paris hospital. I was a hepatologist, and I joined Gilead 4 years ago. Currently, I am in the global medical team, and I am more responsible for all liver disease, but in ex-US countries. As Christophe said, I am in the medical team, so market access, price is not in my pocket, and probably if you have some of this question, it will be impossible for me to answer, but I can catch and keep the question and come back to you with some answer. And I will be very happy to share with you, because we have some slide, the Gilead commitment in liver disease, and I will be very happy to answer your questions on this commitment and on collaboration.
Thank you. Thank you. Let's see who's on the line with us at this stage. Osman, Khalid, Waheed, are you on, please?
Yes, I'm on. Thank you, Dr. Ward.
Right.
My name is Osman Waheed. I'm the CEO of a pharmaceutical company that is based in Pakistan and listed on the Pakistan Stock Exchange. We've been engaged with hepatitis, viral hepatitis since 2003, which was the time of the interferon regimens. And we began producing, we were the first producer of PEG interferon locally in Pakistan. At that time, the cost of treatment was prohibitively high. It was well over $3,000 for just a 6-month course, and often a 6-month course was not enough. With local production, the cost went below $1,000, but it was still beyond reach for most patients. And when Gilead Sciences came up with the wonderful DAA regimens, we very desperately started pursuing a relationship with Gilead because we know what we were producing would soon go out of business. And this partnership began in 2015 with the launch of Sovaldi. Pakistan was the first country to receive Sovaldi under a special access program. And in the first sort of 18 months, we reached over 70,000 patients in a direct-to-patient model under the Gilead Access Program. And since then, the numbers treated have grown to well over 250,000 patients with the kind of results you see on almost every medical conference. It's almost a guaranteed cure. And it's been a privilege to work in this space, despite the fact that we have, the only disappointment is that despite the fact that we have almost a guaranteed cure, the numbers have just continued to grow, which just shows how complex this problem is of elimination of hepatitis. So thank you for inviting me to this conference, and I'm very privileged to be here with you.
Thank you very much. We'll have some opportunities for you to make more comments here in a moment. Let me move in to Dr. Samir Desai, who's a close colleague. He's a member of our executive board at the coalition. Samir, are you on? No. Samir, hopefully you won't mind me saying this, he had a fairly severe accident about a week ago, and so he was really still in recovery a few days ago when I talked to him. So he was hopeful that he could participate, and that may not be the reason he's not participating now, but it could well be. So I just wanted to sort of publicly give him my best. So do you both have slides, or?
I don't have slides.
Okay. I think from Roche, I think we have from Benjamin Labrot, pardon me. He was unable to attend in person, but he did make some video remarks, so maybe we can go ahead and play those now.
Hi, I'm Ben Labrot, the Medical Affairs Lead for Infection Immunity on the molecular side of diagnostics for Roche Molecular. Thank you so much for having me today. I'd like to talk about our hepatitis assay portfolio and some of the new developments. We have a fairly extensive hepatitis assay portfolio. This is a slide summarizing our kind of core lab and serology assays, as well as our molecular assays. I primarily handle the molecular side of things, but we'll be touching today on some of the serology as well. At the moment, we have quite a number of studies running. My core lab counterparts have probably even more studies running. These are just the molecular studies. And what you can see is a trend in trying to push a lot of the research that happens surrounding hepatitis into the countries and regions where it's actually had the biggest impact. One of the difficulties we see with a lot of conditions that affect LMICs is that the research for them typically often happens in centers, in distant centers that are far from the location where the problem is biggest. So we've had really good luck pushing a lot of this research back into the settings where the problem is actually significant. With hepatitis B, obviously, this is, we don't have to tell anyone on this call, this is a pretty big problem, 250 million people, 90% who don't even know their status. And of course, this is a great frustration for us infectious disease folks, since it's a vaccine preventable disease. With diagnostics being both the gateway to care, one of the difficulties that we've had with HBV RNA is how to monitor people, because of course, integrated hepatitis B DNA can still produce biomarkers that have no clinical significance, but can confound diagnostics trying to monitor their actual status. When you're stopping people on nucleoside therapy who are well suppressed, of course, you need to be able to determine and predict, are they going to flare again, so that you can restart their treatment. So we've been looking at HBV RNA as a novel biomarker for management. So far, I would describe the data supporting that as good, but not great. And so by itself, HBV RNA may or may not be an ideal biomarker for this. And what we're looking at now is HBV RNA in combination with other biomarkers to see if we can get a better sense of what's happening with this disease course, and understand, especially in suppressed patients, whether what their risk of progression or flare would be, and they need to restart their treatment. Hepatitis C, of course, this is prevalent worldwide as well. And once again, I don't think I have to tell anyone on this call. The problem is that we've got a great treatment, and that treatment is really not reaching a lot of the individuals who need it. So this goes back to the sense of diagnostics as the gateway to care. For myself, I've been very pleased and also a little nervous about these 2030 targets that the WHO has created. They're very ambitious, looking for a 90% reduction in new infections and over a 50% reduction in deaths. I think this is quite possible, but none of this will be possible if we can't actually link patients to care. And again, this comes back to diagnostics as the gateway to being linked in care. There's a lot of barriers, potential barriers to meeting that third 90. A lot of rural patients. There are more elusive patients. There are the hardly reached populations. And so we have been looking at alternative solutions, especially for molecular testing for HCV. In particular, I've been really leaning into our plasma separation card for hepatitis C RNA, and it seems to perform very, very well. We've got a few studies out now looking at its use in rural Pakistan and elsewhere. Plasma separation card, similar to a DBS, allows you to spot a card with patient's blood. In this case, actually a quantified sample of capillary blood. The blood is pulled through a filtration membrane, leaving a clean plasma sample that can then be dried and reconstituted and used for molecular testing and, as it seems, perhaps some biochemistry testing as well, something we're doing with a lab in the US. So pretty straightforward to use. And the card, of course, is temperature stable and heat stable for quite some time. Hepatitis Delta, also, of course, very exciting. I can now share, as we share this, the Delta Cure, that we have a hepatitis D RNA test that looks like it's going to be very well performing and very inclusive. So very excited next year to start getting this into the hands of a lot of our researchers and letting them start to learn more about this interesting disease. It's a dual target assay, of course, one of Roche's signature strategies, and very, very, very pleased with how it looks so far, and of course more on this as it develops. Hepatitis E as well, there's been a lot of talk about this, of course, in the last year or so. Again, a big part of the world exposed and a lot of people who may have it. We do have both core and molecular and a serology portfolio surrounding hepatitis E, some in development. So this will be some new stuff coming out that also should be very exciting and hopefully very helpful. Thank you so much for having me. I'm so sorry I couldn't be there in person, but I hope you guys have a wonderful meeting and look forward to working with many of you over the coming year.
Thank you. Thank you. Great. Why don't we move on to your slide presentation?
I can go.
You right here?
It would be easier. This way. Okay. So good afternoon again. So I would like to start this talk with the sofosbuvir 10 years anniversary. As you know, sofosbuvir was launched 10 years ago, and currently sofosbuvir, including sofosbuvir generics, are approved in 92 countries. And I would like to share with you this data presented during the last ISLD meeting. So the goal of this study was to evaluate the cumulative HCV patients treated with DAA between 2014 and 2022. And it's very easy. 10 years of sofosbuvir-based regimen, 10 million of patients treated and cured. But if you look at this figure on the left part of the slide, you see a peak in 2019. And this peak is related to the fantastic Egyptians elimination program. And again, congratulations for this program. And this program explains why you have a high number in the center of the slide in red for the low and middle income countries. And Gilead plays an important role in this program by providing sofosbuvir generics at reduced cost. And so we are very happy to see this dramatic decrease of HCV prevalence in this country from 10% to 0% 0.38%. So clearly, sofosbuvir-based regimens have significantly contributed toward HCV elimination, with further efforts required. Now I would like to move to undiagnosed HCV patients with the Legacy program. What does it mean, Legacy? Legacy means local elimination programs leading to global action in HCV. Currently, Gilead supports 121 investigator-sponsored or collaborative studies in 33 countries, including more than 500,000 patients. And this program started in 2016. The majority of these studies is dedicated to people who inject drugs, approximately 50% of the study, and 25% of the study are dedicated to HIV/HCV co-infection. But we have also a very important program devoted to treatment simplification. And we have two very interesting phase 4 studies. The first one has been published recently. It's the MINMON study, showing that with a minimal monitoring, you could achieve 95% of SVR in unselected population. So again, treatment simplification and test and treat approach. And the last study was presented during the last ISLD meeting, so in last November. So it's a French study, it's a phase 4 clinical trial, and the goal is to compare efficacy and safety of 12 weeks of sofosbuvir and velpatasvir in patients treated by specialists and in those treated with non-specialists. And these non-specialists were GPs and were involved in addiction center in the vast majority of the cases. And the key message of this study is that the SVR rate and the safety profile was similar between specialists and non-specialists, suggesting that all physicians could be involved in the HCV treatment, allowing a local management of the patients and a test and treat approach. So again, simplification and test and treat approach. Now I would like to move to diagnosed but untreated patients. And we have this Rolling program. What is Rolling program? It's a recall program for diagnosed but untreated patients. So you have two types of DBU. The first one are complete DBU, meaning that patients had positive HCV antibodies and positive HCV RNA. And you have also partial DBU, meaning that there are patients with positive HCV antibodies, but they were not screened for HCV RNA. So we have some pilot studies in France and in Spain, and now we try to implement this type of program everywhere, and again, recall program and test and treat approach. So this slide shows you all the Rolling programs in the world. As you can see clearly, the champions are the Spanish. And currently in Spain, you have 72 Rolling programs, 72 Rolling programs. And Maria Buti is the first author of the international paper. So if you want to know how to set up this Rolling program, please feel free to contact Spanish physicians or the Spanish Gilead team. And this year, we have a Rolling program, an ex-US Rolling program. And I'm very happy because we have approximately 20 new projects approved. And we have 4 projects in Asia, that is really missing on this map, and also additional in Argentina. So I would like just to finish by the FIND-C program. So as you know, risk factor screening is not highly effective and have a lot of limitations, but universal screening is also not cost effective. So we try to have another option. So this option is FIND-C. FIND-C is the evaluation of a machine learning model in screening and identifying undiagnosed HCV patients. So you should have a large cohort with many informations. You should have demographics, laboratory data, prescriptions, and finally social determinants of health. And when you have all these features, you can build an algorithm. And this study is from the US, and they identify 32 key features related to HCV positive infections. And with this algorithm, with this model, they are able to improve the efficiency of screening at fourfold, meaning that with universal screening, you should screen 20 patients to have one HCV positive patients. But with this model, you should screen 5 patients to have one HCV positive patients. And currently, we are evaluating this machine learning model in Australia and also in France in large database. But again, keep in mind that you should have a lot of parameters, including lab, prescription, social determinants, and demographic. For example, in this US example, one of the strongest features related to HCV infection was use of non-steroidal anti-inflammatory. You have also the distance between home and healthcare facilities. You have also the access to healthy food. So again, large cohort with a lot of information, but probably that. So we need to evaluate in other countries with other database, probably to have different algorithm according to the country. But it could be something very interesting in the future in order to improve HCV screening. That's it.
That's enough. That's a lot. That's very much. Thank you. Any questions for Christophe? There's a lot of fun. That was a great update about the variety of projects that Gilead has supported over the last decade, and they have indeed been one of the strongest, consistent supporters of programs to promote, to study and identify good strategies for testing and linkage to care.
Perhaps I can add that it was very focused on HCV, but currently we are moving from HCV to pan-viral,
Okay.
meaning that it's absolutely possible to have a study with HIV, HBV, HDV, and HCV. And we have other program dedicated more to Delta because, as Maria showed, we are involved in Delta. And probably that next year, we will be very interested to have some program dedicated to women and viral hepatitis. Because we know that the time to treatment, the access could be, could be longer, the access could be poorer, and so we will try to have some data in women. I was very happy to see some data from Africa in pregnant women, but you know that in Europe we have absolutely no data regarding viral hepatitis screening in pregnant women. What is the linkage to care? What is the cascade of care in these patients who have absolutely no data? So we will be very interested to have and to support some programs, some proposals, some project dedicated to women and viral hepatitis.
No, that's good to know. Neil Gupta may have a comment about that later, as we have a registry ongoing, a global registry to collect data for women who are getting treated for hepatitis C while they're pregnant, that we are doing with US CDC. Just wanted to have some other questions from you while we're waiting for some comments from the audience. But getting back over to Osman, please. Christophe mentioned how there was a peak in the number of treatments for hepatitis C and how that's declined. And I was just curious, what is the trend in treatment for hepatitis C, based on, your company's information, please?
So it's a very good question. So I didn't comment the figure on the right part, but during the COVID period, there was a significant decrease. Sure. Currently, it's really depending of the country. In the US, you have a very nice increase, I think, of treatment instauration. If you take the example of Germany, they have implemented a 35 years checkup for all the population, and the number of new HIV patients doubled between 2021 and also this year. So it depends on the effort dedicated to screening, and if you have a strong politic for screening, you find the patients. For example, in my country is really stable, but during many years it was decreasing, and now since 3 years it's really stable. But we try to reach the most difficult to treat patients. We don't have this fantastic Vancouver experience, but it's really a great example. But we try to do our best in PWID. We had also a new target who are patient hospitalized in psychiatric centers, because we know that the HIV prevalence is around 5%, so it's much higher than the general population. And again, we try to screen all viruses, not only HIV, not only HPV, but we try to have a pan-viral screening program, and Gilead wants to support this type of program.
Thank you. Osman, if you can hear me, if you can give us some of your reflections on the trends in treatment in Pakistan, particularly as you're just recently launched a second version of the National Hepatitis C Elimination Program. I'm interested in what you see as the trends in treatment, and what's your involvement of your company in this national effort.
Yeah, no, thank you for the question, Dr. Ward. And as I was mentioning in the opening remarks, despite all the tremendous scientific advances we've made globally through the introduction of DAAs and the phenomenal results they produce, unfortunately, when we began the program in Pakistan in partnership with Gilead, we had a total of 9 million people with HCV in the country. That number has now grown to beyond 12 million, despite the fact that Pakistan has the lowest costs of HCV treatment of any country in the world. The spike that you saw in 2019, Pakistan was a very small part of that. That was the last time we seriously attempted a national elimination program. But as you mentioned, earlier this year, Pakistan again, the government of Pakistan, kind of reconvened on the issue of viral hepatitis. Dr. Homa Qureshi, who's co-chairing the session with you, was instrumental in making that happen and convincing government, particularly the Ministry of Planning, that this is not just a purely medical issue. It's a serious economic challenge to Pakistan. It affects the quality of life of a very large part of its citizens. And so the government recently announced a $100 million commitment over 5 years towards hepatitis elimination in Pakistan. That's the first sort of serious commitment of this nature. Of course, it's not an amount that is enough to actually eliminate the disease. But given Pakistan's resources, I think it's a very admirable commitment for a sort of developing country with a large debt problem to make, committing its own resources to this degree. So we're very hopeful. This was launched early this year around March, and Dr. Gamal is here. We're very privileged to have Dr. Imam Waheed joined for the launch in Pakistan, and we had a series of very sort of informative discussions, eye-opening discussions for the government. So overall, there's a lot of optimism in this last sort of the period between 2019 and this year. We kind of lost our way completely. So you had individual provinces allocating resources to hepatitis elimination, but more often than not, largely because of the way our healthcare system is structured, you had a lot of inefficiencies in the program, and that's my worry going forward also, is that those structural inefficiencies need to be addressed. We had a lot of cases of drug being available and then heading towards expiry because we were just not able to find the patients who needed those treatments. And once we scale up this program with the commitment of the size that I just mentioned, this problem is going to amplify. And the basic structural problem is that Pakistan's healthcare system, like many other developing countries, is like an inverted pyramid, where 80% of resources, government resources, are allocated towards tertiary care, which is the top of that upside-down pyramid, that actually provides healthcare access to less than 20% of the population. And at the community level, there's almost no functional sort of health provision. And that's really the challenge of countries like Pakistan, is unless we reach people where they live and think of new partnerships that enable that, we will not be able to eliminate, despite these serious commitments, despite the fact that we have everything that you would normally imagine would be a challenge: cheap drugs, very effective drugs. The real challenge is going to be reaching those missing millions where they live in their communities.
Mm-hmm. So a couple of follow-up questions come to mind. How is a company like how is a company like yours brought to the table for the national program? Is there a committee, or is there some way of getting industry at the table because y'all are such a key partner?
Yes, so very early on, when the National Technical Advisory Group was formed with the help of the US CDC, industry was a part of that. So I've been personally a part of that tag since the formation of that body. And industry continues to be involved. So just as an example, in the last few years, we partnered with the government of Punjab to eliminate hepatitis C across prisons in Punjab. And that actually has happened. So Punjab's prisons are hepatitis C free, and Punjab is 65% of the country's population. So you're talking about a system of a network of, I think it's about 22 prisons with over 50,000 inmates that were in a period of I think it was 6 to 8 weeks. This elimination drive was very successfully implemented. And now Sindh, which is home to Pakistan's largest city, Karachi, is following suit. And we've also, while the government has been kind of reformulating its hepatitis C strategy, I think worked fairly effective at a micro-elimination level with NGOs like the Health Foundation in Karachi and the Parsa Trust in Punjab to successfully execute micro-elimination projects. And a third element of this, because of the fact that the numbers are so large, 12 million people that need to be found and treated, and only 600 to 1,000 hepatologists, gastroenterologists, you really need to transfer that knowledge all the way, not just down to the primary level, but the primary health worker level. It shouldn't even be restricted to physicians. I think that's what really the realization that we need to have in Pakistan. We've worked with Project ECHO, which is, as you know, Dr. Sanjeev Arora's project around medical education, very effectively now. So I think for the last, it's almost 10 years now that Project ECHO, together with our company and with multiple government and non-government partners, has been making this effort of transferring medical knowledge right down to the primary level.
Thank you. Do you ever you noted the important role of testing and getting people diagnosed in order to get people treated, and that's a big gap. Do you have any experience in actually forming any collaboration with diagnostic companies, given the importance of testing for treatment?
Yes, so in these non-governmental projects, we've often partnered with diagnostic companies as well to conduct screenings. Of course, the cost of PCR still in many cases is really a financial barrier. If you compare it to just soft DAC treatment, it's actually more expensive to diagnose a patient than to cure him or her. So that has to change, but and it has to be done really at scale. So what tends to happen is that these collaborations take the form of screening campaigns based in hospitals. They still don't reach patients where they actually live, their household. Pakistan had the only female prime minister we had, Benazir Bhutto, launched potentially a very transformative health initiative called the Lady Health Worker Program. So we actually have in our health system almost 250,000 trained primary health workers who could very easily be, with a little bit of training and task shifting, become those agents of change that can change the hepatitis equation for Pakistan. And I think that's where the next stage of partnerships really needs to focus, is that primary health worker level and taking screening to the doorsteps. We actually did that very effectively in COVID, in fact. Pakistan was a real success story in COVID-19. And the government of Punjab had a program called RED, Reach Every Door. So not the RED HIV campaign, but it was the Reach Every Door campaign, in which they used lady health workers and female vaccinators to vaccinate people in their houses. And they took the coverage level it was in the low 80s to 98% in a matter of, I think, 4 or 5 months, through an intense kind of focused drive. And that's exactly what needs to happen with hepatitis.
Thank you. You raised a number of issues, good comments on a variety of opportunities. I want to turn to Christophe, Martinaud, and for Cepheid, just building off that last comment about the COVID response, and there was billions of dollars put out to strengthen virologic testing, of which Cepheid was heavily involved, and understandably so. And I just always wonder, how is that response to COVID-19 and building up that laboratory capacity, how can it be applied, to an endemic threats? How do you see the number of Cepheid machines out there now versus 3 or 4 years ago? And if they're out there, why aren't they being used for hepatitis testing? And how can we help them to become platforms for hepatitis testing?
Yeah, thank you. Great question. So there are lots of machines which have been deployed and purchased by many customers around the world during the COVID-19 pandemic. And the nice thing of the Cepheid system is that you are able to run on the same platform with the same performances, many tests, and the performances are the same on point-of-care testing as compared to centralized lab testing, which is very nice from a laboratory medical standpoint. That said, the market during the COVID-19 was so big that it drove the companies to invest in this field in such a short time. And currently, we have to use the available systems to implement more tests on them when it is needed. And by doing this, we will use people who are already trained, machines who are already available and sustained and implemented in healthcare systems. And this, in a way, will decrease the overall cost of the test, of the implementation of the test. And to come back to this very specific issue of the cost, of course, we can look at the cost of every cartridge and think that the cost is always too high, as for everything in our life, I think. And what we need is to consider the overall cost of implementing point-of-care testing or rapid testing, or the overall cost of having the result available where it is needed, when it is needed for the patient who require the result. And even if in many situations, the answer to the question is it worth having the test available now is very obvious. Okay, of course, we need the result now. because the patient is here, the physician is here, and maybe tomorrow the patient will not be here, the physician will not be here, and when I send the sample to the central lab, I don't even know if the sample is arrived. I don't know when the result will be available, and maybe I will have to retest the sample because there is a shortage in, I don't know why, no what, but the sample is not available anymore, and the patient is gone, and the physician is gone, and in some studies, you know that half of the samples who are collected to be analyzed, half of them do not have any result at any time. So we can consider the cost of per test, but we also have to consider the cost of transportation of the patient, transportation of the sample, retesting of the sample, retesting of the patient, and so on, the basic overall cost. And we also have to consider the health economic cost of having a result and treat a patient. And this was shown in many papers, many studies, for many diseases actually, that when you treat the patient, you avoid extra costs due to the progression of the disease. And this point is also quite obvious for everyone, but as for the first part of the overall cost that I mentioned just now, and this one, the health economic cost, we need evidence. We need evidence to go to the payer to show them that the cost which is endorsed by the lab, the cost which is endorsed by the patient, in many cases, in many countries, this cost is lower than the cost that the society, the public health will endorse if the patient is not diagnosed, treated, and followed up. And to do that, we need the collaboration between all the partners involved in the management of the patient, and we also need the patient to be involved in this process. First, to be able, from a company standpoint, to develop the best test, meaning what kind of sample device do you want, what kind of sample type do you want, because it's not the same defining this at the very beginning of the development of the test, or asking this when the test is already on the market. It's totally different from the company's standpoint to change something which is already available as compared to building something which will be very convenient to the final user, the end stage user. What are the targets that are required? Do you want one target, two targets, HBV and HDV? Do you want something else? Do you want a viral load? Which quantification, which limit of detection? You want to link this to a treatment, to a management of the treatment, to a drug, a specific drug. This is very important to be defined at the beginning, as well as the intended of use, because an in vitro device currently in many countries is labeled and as is intended of use, just like a drug, and this intended of use has to be defined at the beginning, and it is related to the clinical studies that the manufacturers have to provide to the regulatory to be able to be on the market. And if it is well designed at the very beginning through the collaboration of everyone with the in vitro diagnostic company, it will lower the cost at the end. And the last point, sorry, I'm a bit too long regarding the answer of the question, but the last point is that when we are performing clinical studies, pre-launch clinical study, we have to include in these clinical studies the cost effectiveness of the study, because as mentioned for many other aspects of the problem, if it is scheduled at the beginning, it will be more effective. And if it's done after, we can already do the work after. We need to design the study and to provide the cost effectiveness very appropriately to each one who will use the cost effectiveness study. Because if we have a target and that the payer is expecting for another one, we just have lost the time for everyone and every patient.
Thank you. You mentioned, you were mainly responsible for different types of studies and evaluations, and just getting back, I don't want to turn this into a group therapy session about, COVID-19 response and some of the barriers to hepatitis testing, but one of the barriers that came out very prominently in the response to COVID-19 was these silos of testing. and how a Cepheid a gene expert was available in the TB clinic but wasn't available in hepatitis, and there was a big push to reduce those silos, as they're called, and really make it a more responsive health system. And you're the manufacturer of these machines. You're not the be all and end all to solve every problem. But I just wondered if this looking at how to integrate gene experts in health systems so it can be used for multiple purposes is one of your objectives of your research, please.
Yeah. So the answer will be easier because the answer is yes.
Good, let's go.
Yes, and we learned this from the COVID-19 that there were some barriers to implement tests on machine, which was basically paid by someone for specific purposes and cannot be used for another purposes. And this is starting to change, and for sure it will never be the case anymore. Yeah.
Yeah. Yeah. I know that was a real problem for like TB programs, and they couldn't be used for HIV in particular. I mean, Hep C in particular. Two other questions come to mind at the moment. Dr. Osman mentioned the importance of the national programs, and I think you were speaking of. We have these very affordable treatments, but they're not getting implemented, which brings up the need for national commitments for good testing, linkage to care and treatment programs. And just wanted to give you both an opportunity to highlight some countries you may have worked with to get their, well, for a start, get your research findings in front of policymakers or treatment guidelines preparers, so that a very effective strategy like the MinMon approach gets adopted as a policy rather than just floating out there as a research finding. It's all about translating the data into action. So I just wanted to see if y'all, you feel like that's part of your work, or is that your government affairs program or what have you, but just if you give some insights to how you might play a part in that activity.
Yeah, yes, it's a very interesting point, and as I mentioned with the Helios 3 from France, it's a very important study because we can show that the treatment outcome is absolutely similar between specialist and non-specialist, and it could suggest that all physicians could treat. And when you look at the local management test and treat approach, we know that in the vast majority of the countries, HCV treatment is only for specialists. So based on this study, perhaps we could extend the prescription to other physicians. And if we extend the prescription to other prescriptions, it allows to have a local management and a test and treat approach. And so it could be, it's one, I think it's a very good example. It was exactly the same from the MinMon. We have some recommendation to simplify the access, to simplify treatment, but we didn't have data supporting that. But with the MinMon, clearly we show that we don't need to have an extensive pre-treatment monitoring, on-treatment monitoring, and post-treatment monitoring. So again, we are in the simplification, and these data support the treatment simplification recommendation of the liver societies. Yes.
Thank you.
Yeah, exactly. The same approach can be applied to diagnostic as the first step of treatment. And the 2022 WHO recommendation about the task shifting is very interesting in that way, thinking that we can transfer the prescription from a specialist to a non-specialist, a well-trained specialist, non-specialist, of course. Yeah. Training is pivotal in this settings, and as well for the testing. So in some countries, we just need, if just is the right word, to provide evidence that it's doable and safe for the patient and cost-effective for the payers. And in some other countries, there are also some regulatory barriers, especially regarding laboratory medicine and laboratory testing. You know that in the US, there is a specific regulation for point-of-care testing, the CLAI regulation, and in Europe, at least in countries which are applying the ISO 15189 certification, laboratory testing has to be supervised by a lab physician. This is not very easy when you're thinking of point-of-care testing, especially to reach to this specific population. And if you just take the example of HCV patients who will not go to the hospital, and you have to go there and meet them where they are living and bring with you the treatment and the point-of-care testing. There is currently a barrier because only a lab can perform the point-of-care testing. And looping back to the 2022 WHO recommendation, I think that the policy has here the voice just to make this change, because many things have changed during the past decades in vitro diagnostic techniques. And even if for some analysis and the main part of the analysis, you have to perform this in a very well-defined laboratory, the progress in technology afford to perform very safely and with very high performances the same assay outside of the lab with well-trained people. So we are really working on this, bringing evidence and supporting study, which aim is to provide those kind of evidence. Yeah.
Thank you. You know, here at this meeting, you've heard a lot about hepatitis B and the increased attention to hepatitis B, diagnosis, care, and treatment. We have a research roadmap. We have an upcoming WHO policy revisions. You had some examples of models of care already. Just wanted to, I think you touched on moving more toward hepatitis B and as well as Delta. So I just wanted to give you a few moments to, you know, expound on that and the direction you may be heading in terms of studies or, you know, other initiatives for project development. And I guess we just go left to right here, if that's okay. You want to start?
Yes, so regarding hepatitis B, we have two main strategies. So the first one is to improve screening, because we know that, for example, in my country, in France, we know that 70% of HBV patients are not identified. 70, it's not 17, 70.
70.
70. So we know, and it's why currently we try to have pan-viral project and proposal. The other very important point is to extend a treatment indication, because by the past for liver society, the treatment indication was based on fibrosis progression. But currently, probably that the good indication is to prevent HCC. And so we need to provide and to support studies providing data showing that, for example, patients from the gray zone at a risk to develop HCC, and that these patients could be included in the guidelines and for extending a treatment indication. So currently we are supporting some studies from Asia, but you know, when you discuss with the European KOLs from data from Asia, oh yes, but it's from Asia, it's not the same background, the same genotype. So we are also supporting some study in Europe in HBV patients, and especially for these patients from the gray zone. And we hope that EASL guidelines could be changed, modified, and extended in order to prevent HCC in all HBV patients.
Mm-hmm. Thank you.
Yeah, so about HBV and HCV, so and HDV maybe. So we are working on an assay on HDV. We don't have any time frame to provide to you, but it's in the pipeline. and regarding HBV and HCV, so it's modification of claim, and especially for the HCV to get the CLEA waived in the US. We're also working on the fingerstick claim for HBV, as we already have it for HCV, and that's the main modification that we will bring to our assay in the next years.
Thank you. And Dr. Osman, do you have any, I'm sorry. Dr. Osman, do you, are you have any involvement in developing hepatitis B drugs, even generic versions of the current therapies, or are you involved in any way in looking at functional cure development?
Yes, we do some production of HBV drugs, and we're in talks currently with Gilead to expand the portfolio to the full range of HBV treatment. But the real problem, the real challenge is really not the treatment part anymore. It's still the diagnostics. And I just wanted to make sort of one comment. It's just food for thought.
Sure.
What's worked really well in the pharmaceutical world is, I think Gilead has led this, is this competitive voluntary licensing model. If you were to do cost-benefit analysis today, you could still justify charging $1,000 or even $3,000 per cure for a disease like hepatitis C, because economically it would still make sense. But the fact is that a lot of poor countries around the world are really constrained by their capacity to financially pay for programs that screen and test and treat patients. And that's really where I think a similar success story needs to come out in the diagnostic space, John. I mean, if you look at both, in fact, we discussed COVID a little bit, perhaps more than was needed in a hepatitis meeting, but even in COVID, remdesivir was kind of the first therapeutic to be approved. 6 and then ultimately 9 licensees were selected to supply the treatment to 127 access countries. And in the end, the results were truly remarkable. I mean, countries in the Caribbean that otherwise would never have had access had almost in parallel treatments available to their hospitals as countries like the US and Europe and Japan. That was the scale and the speed of that response because of a competitive voluntary licensing system. And because it was competitive, which means every licensee competes with every other licensee in these markets, the costs went dramatically down. I think by the end of the pandemic, they were about 10 to 15% of what the original costing was. And we've seen that in hepatitis C also. If you're looking at a soft DAC cure of, say, $30 to $35 per patient, compare that to $3,000 with peg interferon. I mean, so it's been a dramatic reduction. And as I said, the cost-benefit analysis would still show benefits from a much higher cost. But the fact is that a lot more patients can now be treated and cured because countries can afford to do these things at scale. And perhaps, I know it's much more complex in the diagnostic space, but just thoughts around a similar model would really be very, very useful if we're actually looking to eliminate these diseases.
Thank you very much. Well, thank you. Thank you for your thoughts. Really greatly appreciate it. Let's give everybody a round of applause, please. Thank you.
Thank you.
All right, we're going to close it out here. I'll let Huma open this up. Ladies first, always.
No, there's some closing housekeeping.
Oh, we do? Okay.
Yeah, so thank you. I've been given these housekeeping messages, which I have to pass on again. It's a reminder to all the attendees to complete the online post-meeting survey, which will be sent to you on the email. And as told earlier, the delegates who complete the post-meeting survey will receive the certificate of attendance and the CME credits. And and I think that's for me to really say. And then obviously now when we're coming to the close of the meeting, it's been a real pleasure, and you people have been really very interactive and good audience. And we heard so many good stories about elimination in Egypt, and then the CSO working in Egypt to really eliminate the disease. But then we also saw issues regarding the access, regarding the affordability, and we heard about discrimination. So issues are still there. Despite everything really moving on a fast agenda, we still have issues. But then we heard that there is a way forward with simplified testing and treatment guidelines, task shifting, and then decentralizing and decentralization. So this is again things which are really moving the hepatitis agenda forward. So I think, and we heard that hopefully next year the many countries would be eligible for the Hep B vaccine through Gavi, which is again a good indicator that the disease would obviously go down very well. So I think we heard in the 2 short days, it was 1.5 days, we really heard very good lectures and very good participation from all of you. So thank you.
Thank you.
Sure.
Well, I want to thank HEM and all the organizing committee for getting this together, and the scientific committee that helped with the agenda development. I really enjoyed this meeting, very much. I think we really can have mission accomplished. I think we get a good update about the status of hepatitis elimination through participation of WHO, the information I shared from the profiles, hearing from the regional perspective and national perspective and individual projects. I think we've gotten a good, really a good update in a variety of different ways that HEM has already, touched on. But I hope you really can see that we are making progress toward hepatitis elimination. Sometimes it's in fits and starts, and it's not as rapid as we would like it to be. But we are eliminating, hepatitis, and we, as demonstrated in this room, we have a lot of passionate, committed people that are staying the course until we reach those goals. But progress is being made. And we raise the challenges to overcome them, and we had examples of how they are being overcome at the project level, subnational, national, and regional and global level. And that's what really, I feel very energized now, and when I leave these meetings, because it's the opportunity to get to work with people like you, and I really sort of get new juice in my battery, if you will, of going forward and working as hard as I can to do my part toward a hepatitis elimination. And I hope we can continue to be a resource for you and for us to be a resource for each other as we've strengthened our relationships by being together over this last day or so. So please keep in touch. Please fill out the evaluation so we can have a good meeting next year. Right around this time, we'll give you the exact dates in a few weeks, but be looking for that, and please keep in touch, and let's all work together to eliminate hepatitis. Thank you very much.
And thank you to the IVHEM team.
I will. Thank you. I do want the people in the back. Thank you very much. I talked to Michelle, Jasper, and the staff. Thank you for a job well done. Excellent meeting. Excellent refreshments. Everything was good. So thank you very much. Y'all have a good, safe trip home. Thank you very much.
Thank you. Thanks.